Welcome to the New Dentist Study Club podcast. My name is Dr. Sanj Mohanta. We're going to learn about clinical management, practice management, and the emotional management of dentistry. Let's learn how to be happier in dentistry. Let's go. Hello, everyone. Thank you so much for joining me again for another special podcast. This time it's with the legend, Dr. Dennis Marangos. He is joining us today to answer all of your burning questions on restorative dentistry. And he is also going to share a case presentation. So for those of you watching on YouTube, you're going to see his great work. And for those of you listening on Spotify and Apple Podcast, he is going to do a great job explaining everything. So you'll be able to follow along, whether you're watching or listening. And these are all the questions that I have had over the last 26 years of doing dentistry. And these are the questions that many of you have asked me. So we're going to have our expert Dennis answer them all. So Dennis, welcome to the pod.
Thanks, Sanj. It's an honor to be here. I really admire your group and trying to get young dentists passionate about dentistry.
Oh, Dennis, you get me passionate because you've been doing this for many years. I love how you're doing dentistry the right way, that you're teaching us to do it the right way, and that you have so much passion that you're making us want to excel and be better. So that is the point of having you here. So Dennis, tell us a little bit more about yourself. Where did you go to school? Where are you working now?
Well, Sanj, I'm a graduate of U of T, 1986. We're coming up to our 40th anniversary.
Yes.
I did a residency at Mount Sinai after graduation. I was there for almost 2 years, and from that point on, life just changed. And I remember taking one of my early, let's call it a cosmetic or aesthetic adhesive dentistry course with Ron Jackson. And Ron Jackson was all about partial coverage restorations in the day. And he introduced us to a product back in the 90s called Concept by Ivoclar, which is a composite precursor to the whole Emax line. And once I started doing that type of dentistry, it was just a chain reaction of what we needed to do. The University of Buffalo, of the State University of New York in Buffalo, had an aesthetic program that was 6 months. And so we'd go there every weekend for 3 or 4 days, learning from all the legends. And you have to appreciate back in the 90s, there was essentially one adhesive system, John Kanka and Allbond. John Kanka developed Allbond, and that was what everybody was using. And today we have, I don't even know how many are out there that we can choose from. And some of the questions that you're going to be asking are going to pertain to the adhesive choices and reasons that some dentists are more successful than others in creating long-lasting restorations. So I'm practicing in Toronto, still not practicing a lot, but I'm practicing 2 full days a week in my general practice. And I have a practice 1 day a week devoted to TMD, craniofacial pain, sleep apnea, kind of occlusal issues, and pretty much all the patients that you guys all out there don't want to treat, they end up in my chair.
Thanks, Dennis. And at the end, before we sign off, I'd love for you to share what keeps you happy in dentistry after 40 years. So it's going to keep the audience engaged for the whole episode is
Looking
to
forward to
hear
it.
that at the end. But I gave Dennis, a list of questions, so we're going to go through it rapid fire. So here's the first question. When you do shallow fillings, like those shallow occlusal restorations, why do people get sensitivity after that?
Okay, that is when I saw that question, that was perfect because back in the day, when we started doing this, I thought I'm going to start by just doing occlusal composites because I figured how can you mess that up? It's so
Yes.
simple, right? It's very simple. There's something out there, something called the C factor, which is the number of bonded walls versus unbonded walls. An occlusal restoration has the highest C factor, which means that when you polymerize that restoration, that composite, it has the tendency to bring in the walls of the periphery of the restoration and cause pressure. So every time the patient bites, it causes pressure. It's causing pressure on the dentinal tubules. The enamel, the cusps are moving and causes pain. So what we had to do in those days, this is how we relieved that. You took a 330 burr and you cut right through the central fossa of your restoration, released that pressure, and then just filled that back in. Now, in those days, we didn't have flowable. So you had to use your regular hybrid composite. So the C factor is pertains to that one question. Occlusals are the one class of restorations, those class ones, that have the most post-op sensitivity. Depending on how wide and how big the cuspal inclines are, occlusion, hyperocclusion plays another factor in that. So you've got two major things, but C factor is the number one answer to that question.
Okay, thanks, Dennis. So how do we prevent that if we do have a wide, shallow occlusal
Well,
restoration?
these days it's actually pretty simple. First of all, I know we're going to get into this at some point, but total etch is all
Okay,
I've done since the 90s. That's it. And
that's all I do.
it's the gold standard. You have to
Yes.
do it properly. Now we have some bulk fill composites. So Ivoclar, I'm going to be mentioning products. I do not get paid by any company. I didn't invent anything. If something stinks, I'll tell you about it. If something's really good, I'll tell you about it. But it's through my trial and error that your viewers are going to gain the best knowledge. So Ivoclar came out with Power Flow and Power Fill, Tetric Power Flow and Power Fill, a bulk filled composite system, and that word is key, system that allows you to polymerize up to 4 millimeters in one layer. Their flowable has the least amount of shrinkage as any flowable on the market. So it's less than 2%, which means in your proximal box, you can fill that up 4 millimeters and polymerize for 3 seconds using their light. So,
Okay.
so now there's all this chemistry and all this science going on, but essentially those big wide preps now, if you're using the proper composites and they're bulk filled, you can get rid of that sensitivity. The other way to do it is if you're not confident with a bulk fill, is you have to layer the buccal inclines, polymerize through the buccal cusp, then layer the lingual or palatal surface, and right in the middle is your central fossa, which creates just a very, very thin composite joint going right down the middle. So layering
Mm,
in 2 millimeter increments with a conventional composite is the other way of doing it,
okay, good. Can you name that system again from Ivoclar?
called the power fill system. So it's Tetric
Okay.
Power Flow, Tetric
Okay.
Power Fill, and their light, the
Tetric
blue phase,
power flow and tetric power fill. And what's the name of the light?
the
That
blue
3 second
phase,
light.
the blue
Blue
phase.
phase. Excellent. Good.
Yeah. Yeah. So it has
That,
all the settings, and what makes this bulk fill composite different is that originally when we were doing bulk fills, they had to be very translucent to allow the light to polymerize
mm,
the base. This has two initiators, two photo initiators in it, which allows you to cure and polymerize in a 3 second cure. Very powerful. And when you see the case, you'll see that you don't see anything because it's shade matched. And the beauty of it is it's not a gray looking composite.
oh, excellent. And then how about that leads to our second question. How do you decrease postoperative sensitivity?
So that has always been a question. And I have a unique story within my practice. We had a hygienist who was working in the practice who was a dentist, graduated from U of T. And so he went back and did his program. And he was asking me, he goes, I see some of your composites that have been there for 25 years. They look brand new. What do you do? And this is a new grad who came out. So my question is, well, what are they teaching you? Well, what we do and what I've done forever is total etch. You have to re-wet your dentin with either chlorhexidine or a product called G5. G5
Okay.
took over from Gluma. When the patent ran out on Gluma, Clinician's Choice started manufacturing G5. And G5 is the best desensitizer, antimicrobial, and antifungal that reduces that sensitivity. So you first of all, you have to know what your adhesive system is.
Yeah.
Second of all, you have to clean that etched surface so that if you're using Optibond, which is what I use, Optibond FL, and when you're putting in your primer, that glistening surface sucks the primer into the dentinal tubules to create the seal. So then when you put your adhesive layer on top, you have the hybrid layer or your plastic dentin that's recreated. So that's one way. The other thing that we run across in my practice, we have a lot of aging patients. You have a lot of old amalgams in there. You have a lot of sclerotic dentin. Sclerotic dentin has to be etched twice as long as, let's say, unsclerotic dentin, younger dentin.
Wow.
Even at that, and we do pumice, air abrasion, double the etch time. And those are the steps that you have to take to ensure that you've got a clean surface. Even at sorry, just drop my pen here. Even at that, that is the only time I will use a liner in sclerotic dentin when I think it's so deep, not because it's close to the pulp, but because it's so deep that I don't think I can etch the dentinal tubules properly. And I will use Fuji 2 light cure base material, and then we'll do our total etch protocol on top of that. So Optibond is your total etch number one. Fuji as a liner in sclerotic dentin when you're unsure, doubling your etch time and using G5 or chlorhexidine as a re-wetting agent after you've etched.
Wow, that's incredible. So you mentioned something that you only use a liner when you have sclerotic dentin.
Yep.
So you're not using it for really deep
Nope.
restoration?
Nope.
What are you using? You're just
Total etch.
etch bond.
Yep.
Wow,
Yep. Yep.
that's
Yeah.
okay.
Because
And why?
because if I'm confident, let's look at an aged patient. That pulp has receded so much. What are you protecting? It's only the
Yes.
sclerotic dentin that you can't guarantee the quality of the etch and the quality of the seal that makes that a problem. Otherwise, if you're using something like Optibond, and I saw that you said you are, when you put
Yeah.
that adhesive layer on, that's like a flowable. That's thick, and it needs to be relatively thick without pooling to give you that cushion. If you're confident in your protocol, and if you're using rubber dam, and you're not getting saliva contamination, okay, so now we're just covering off a whole bunch of other little
Yeah.
little questions that lead to post-op sensitivity. I mean, we use rubber dam on everything. I use rubber dam on crown preps. You like
So do
rubber
I.
dam automatic. My assistant knows. She pre-punches rubber dams for every quadrant, and they're ready in the box.
That's great. Yeah, it makes it so much faster. Once you do it more, you'll be able to place it really quickly.
You know
So
what?
it doesn't take much time.
No, and somebody they teach us rubber dam in school. The minute
Yes.
you graduate, you get rid of it. I had a patient tell me that her dentist said only bad dentists need rubber dam. Yep.
Scorebowl.
And that was many years ago. And now she loves the rubber dam. Everybody just loves it because you don't have to do anything.
Yeah, it's true. And it's great. Like your hands are free to do
Yep.
the dentistry and
Yep.
not to,
Absolutely. Mhm.
hold cotton rolls. So that's great. So even for like a younger patient, if it's a big cavity, you still would not use a liner?
Nope. Nope.
Okay,
Now,
that's good to know.
okay, if it's a primary tooth, I may just use Fuji 2 as the restorative material.
Yes.
Okay, in a primary tooth. Okay.
Yeah.
In a permanent tooth, again, if there's a mechanical exposure, Then I will use a product called TheraCal,
Yeah, I love that.
overlay that with Fuji, and then restore the tooth. If it's a carious exposure, that's endo.
Yeah.
So
Okay.
yeah, because it's so hard when it's a carious exposure to determine how clean that tooth is going to be. So,
Exactly.
yeah, yeah. So
Okay.
that's where I do. So the use of liners, it's minimal.
Okay, good. I'm glad that you mentioned Fuji too, a glass ionomer. Do you use glass ionomers for your class 5 restorations?
Okay,
Or what
depends.
else?
Tell me more
Okay.
about the class five. Tell me about the
Oh
patient.
yeah. Okay, say it's non-caries class 5.
A
It's from
non-carious.
erosion or abrasion. Yeah.
Okay, so if it's abrasion and it's a non-carious lesion, you have to look at this and say, okay, am I replacing, is if there's gingival recession, am I replacing lost gingival tissue or lost tooth tissue?
Okay.
If you are trying to put a class 5 in an area where it's lost gingival tissue, that patient is going for a connective tissue graft. If
Mhm.
it's lost enamel, then I will do my total etch and I will use a flowable composite, not Fuji. The only time I'll
Okay.
use Fuji is if it's on cementum or root decay.
Okay. That makes sense. Thank you. Okay, here's another question. How do you, like, what causes those white lines in restorations and how do you avoid them?
That has been one of those ongoing questions. We never really knew, but the research and the literature and kind of the chatter around the coffee bar at conferences is that it's a lack of a bevel or an insufficient bevel, because you're going to see it primarily on anterior teeth. Okay, let's
Yes.
talk on anterior teeth first. It's you need a long, infinite bevel. Everybody's too shy with their bevels. Make it long and infinite, and you have to adapt that composite into that bevel onto the enamel of the tooth so that when you're polishing, you're not overheating the composite and creating, the grout in your bathroom tiles? That is a white line. So by over polishing and overheating that margin, you're going to create a divot, and the dust from your composite will fill those
Okay.
voids and be your white lines. So the other component to that is everyone says, well, this composite is so stiff, I can't massage it in. We heat every single composite, including our flowables.
Nice. I was going to ask that question next. Do you warm your composites? So you do.
Every single one, every single composite gets heated, and the research has shown that it actually improves all the mechanical properties of the composite. It doesn't
Really?
weaken it at all, at all, at all.
So do
And
you have to use a proper composite warmer or can you
I
just use like coffee warmer?
No, because it doesn't get hot enough. You have to
Oh,
use,
really?
yeah, you
Okay.
have to have a composite warmer. And what'll happen, the minute that you do that the first time and you go to squeeze your composite out, you're going to pretty much expel the whole compule. I use compules, not syringes, because
Okay.
it just flows so much. And then eventually you'll get used to that, and
Okay.
you'll see that you're going to end up using composite.
Okay. Thank you. So that leads to my next question. How to avoid voids? So warming your composites, is that how you avoid
For
voids?
one, absolutely.
Okay.
And where are you talking about voids?
In actually, like you don't even see it until you look at the bite wing 6 months later and you're like, oh, there are voids in this restoration. Like
S-
it might be in the box.
Okay.
Yeah.
So, so that's an interesting question because back in the 90s when I was and you look at your bite wings, you'd go, oh my God, that's recurrent decay, or I left decay. And
Yes.
the number one thing you're likely seeing is pooling of your adhesive in the corners of the
Okay.
top of the box. So if you apply your adhesive properly and you use a flowable in the proximal box, you will not get any voids.
Right. What if you see voids between your layers?
Why are you
Why
layering?
are you layering?
Like 2 millimeter increments. What if you
Why?
see like, I mean, oh yeah, because you just said use bulk fill.
That's right.
Then you're not
That's
going to
right.
get
That's
voids.
right.
Okay.
So here's the problem with layering. As you're putting each layer, one of
Yeah.
the mistakes that a lot of
A
dentists
lot of
make
dentists think
is that
is
on
that
the first layer, they may use some of their
they're
dentin adhesive to
Okay.
re-wet it, to wet their instrument.
Mm.
And then you're going to put your
they're
next
going to put
layer
their
on
neck
top.
on
That creates a gap, a
Okay.
microscopic
micro
gap. The composite doesn't
composite
join.
doesn't
Mm.
So what you should be doing
should
is
be doing
not applying your dentin adhesive to your
your
instruments
instrument
because you're going to
because you're
create
going to
a void. And a meniscus is going to
this is
form
going to
under each layer, and you're going to get a crack in that proximal box.
Okay.
So yeah,
Great.
so yeah,
the only place you
only
may
place
want to consider layering is maybe on the occlusion.
maybe on the occult.
Okay. Good. So a lot of our other questions can be answered with your case presentation. So would you like to share your
Sure, let's go
screen?
there.
And then we're going to explain everything. So if you're just listening, you'll be able to follow along.
Okay.
Okay.
Are you sharing
Are you
yet?
sharing yet?
Yep. So you can share. I've allowed screen sharing.
Okay, there it is.
Yes.
So, so Dennis, you are going to show back to back to back restorations, like three, is it three restorations all beside each other? And
Yeah.
then starting with amalgams.
Well, let's have a look at this case. So this case came
Case.
in. I did this last week or just the week before. The images here are a little grainy because all these images were taken with my intraoral camera, which we
They
use
look great.
every single day. Okay, all four rooms have the cameras, and we do that. So this is 252627, and this is an example of a patient that goes to the dentist every 4 months. New patient to my practice. Okay.
Right?
So what we see here is we see right here there's interproximal decay on the 5. We can see there's recurrent decay on the 6 as well as the 7. So the biggest question that I get is when do you know or when do you decide to change the amalgams? Well, in all my years, it is so rare to find no decay under an amalgam. There's something,
Mm.
there's leakage all the time. So the
Okay.
other thing that we have to do when we're doing composites is we have to forget about amalgam and relearn composite. You have two
Okay.
different materials with two different techniques. So when we look at 2.7, now, let's go back. You're looking at 2.7 and you're saying, okay, that's not too bad clinically back there. But when you take
Yeah,
it,
2.7 has looks like an occlusal amalgam.
yep, but look at what happens when you remove the amalgam and the decay. There's
Yeah, it's a lot bigger.
so
Prep is so much bigger than I expected.
So what I'm going to tell you is both the 6 and the 7 have been treatment planned for crowns. This was the caries management step. So I'm going to do caries management and his whole mouth, and
Okay.
then we will get to the indirect restorations at some point. But when you're
Okay.
looking at this here, there's a sample of sclerotic dentin that might you might consider Fuji on that, but
Okay.
okay. So now you can look at the 2.6, and now once that amalgam is all taken out, you see that you have a very large restoration
Yeah, large MOD restoration and deep
and deep and unsupported cusps that are really a challenge. But the one thing
and wide margins. That's going to be
very
a hard
wide.
restoration.
Absolutely, it will be. And the one thing I do want to point out is in preparation design. So when you look at this image of the 2.5, you can see that I've left a couple of little sharp edges there, but this one down here, they've been all smoothed out. So your
Okay.
preparation is a composite preparation, not a GV black amalgam preparation. And
Okay.
And that's where people don't kind of get the system. There is a composite preparation. Now, there is no actual bevel on the occlusal margin, but I do take a a finishing diamond, a football shaped diamond, and I just soften that edge. You can almost see it there, where it's not a bevel, but it's a ledge so that the composite can actually sit on the
Okay.
tooth. Okay.
So that was the 2.5 DO. You said you use a football finishing burr to bevel the margin. Do you
Yeah.
bevel the interproximal margins as well, or just the
No, I
occlusal?
just clean that all out. Okay. So what you
Okay.
can see here is so now I get questioned all the time about doing back-to-back multiples, how to get
Yes.
contact. If you tried to get contacts on all these teeth at once, you would fail for sure. It's just too much work in one area. So
Yes.
typically what I do is I will restore the middle tooth to completion.
Okay.
Then
All
you
right.
see our next step. So what I'm using here, and you can see the remnants of the air abrasion that does,
Okay.
so everything's been
So
air
you use
abraded.
pumice and air abrasion?
Absolutely. I
Okay.
because patients, as much as their uh, hygiene is good, there's plaque everywhere, and you cannot
Mm.
etch through plaque. And
Yes.
air abrasion sometimes doesn't get the biofilm out. So we use pumice and air abrasion. So that's why these preps look so clean. So
Okay.
we're using a product here by Garrison. It's called the Real Matrix. And that's what you're seeing, that green kind of little stumpy thing with the yellow.
Yeah, it's not a sectional. It looks like a
No.
Tofflemire.
Yeah,
So it's a
without,
real matrix. And
yeah,
2.6 is an large, wide MOD
MODDL.
preparation.
Yeah.
Yeah.
And the real matrix, so that's REEL matrix, without the Toffelmeyer part, because how would you get a sectional matrix through that Toffelmeyer, which presents to be a problem for a lot of dentists?
Yes.
So now you can see on the distal of the six, we are able to use a strategy of a sectional matrix ring with the real matrix. So dentists,
That's my favorite ring.
there you
The
go.
Smirk Blue Strategy Garrison ring. So
Yep.
Dennis is showing on the screen the 2.6 MOD with the real matrix by Garrison and a blue Garrison ring on the distal.
Right. So now you've got the contact on the distal of the six, and you can be confident that you're going to get this. Garrison has come out. Let's say you were just doing a back-to-back on a four and a five. They've come out with a new system called the Quad Force.
I love that. I have that.
That
Oh
is
my, that is, I
that
probably
lights
spend
out.
any time finishing. I have a
Nothing.
great contact with Quad
Absolutely.
Matrix by Garrison. Everyone has to buy that. When you're doing
Absolutely.
back-to-back MODOs, oh my God, it saves so much
Absolutely.
time and stress.
Absolutely. So now with the real matrix, you're going to focus on finishing this. When people say, "How do you etch?" That's how I etch. I just fill the
So
matrix.
you're, so for those of you who are listening, Dennis has like put etch on everything, not just on the prep, but also on the cusp. On every
Everywhere.
single surface of the tooth, there is etch.
And you know why you do that? Because your composite is going to go flowing up those margins into that
Yes.
infinite bevel so that when you polish it, you're not going to get white lines. Okay. I'm not
Oh, that's
afraid.
great.
I'm not afraid of etching the tooth because I'm confident in my adhesive protocol. On
Yes.
the slide on the right, what you're seeing there now, hold on, let me just show you here. This is Tetric Power Flow, the bulk fill flowable that gets lined and filled almost to the top of the pulp of the cavo surface margin. You can almost fill the entire proximal box. And
Wow.
2 3-second cures, and there it's solid.
So that's you built it up 4 millimeters with the
That's
tetric
for
flow.
Yep, to the flow. I bring it up to the level of the pulpal floor if that's about 4 millimeters. So I typically, if I'm unsure, I will measure with a perio probe and just say, okay,
Yes.
I know where to stop. I know where to stop because I know it's not going to go any further. So this is
Yes,
two.
so Dennis. Yeah, Dennis has showed that he's using the Tetric flow in the mesial and distal
Power flow.
boxes.
Power
Power
flow.
flow. That's right.
Because
Power flow. Sorry
they
about that.
have another flowable. Don't
Yeah,
confuse
that's
them.
true. That's true.
Because
Power.
if you're trying to do a bulk fill protocol with a non-bulk fill material, it's going to fail.
Okay.
Okay, so you have to look at that. So now in this case, if it was a smaller preparation, I would have just filled the whole thing up at once. But in this case, what I'm doing is contouring the distal margin so that I can get good anatomy, make sure that I don't have to over polish afterwards because over polishing overheats the composite, creates white lines. So in this case, I did the distal half of the tooth, then I finished the mesial half of the tooth with the tetric bulk fill, and then what you're
Okay.
seeing on the far right is the initial finished look for tooth number 26.
That's beautiful. Now, Dennis, I have a question.
Sure.
Because you started off with the ring, the Garrison blue ring on the distal. You built up the distal. Then did you move the ring to the mesial when you built
No,
up the mesial?
no,
No. Okay.
I'm going to show you what we're going to show you
Okay.
what we're going to do next. Okay. So once I've done this, and I know I don't have to add composite to this, I put a layer of glycerin over the composite, light polymerized through the glycerin to eliminate the oxygen inhibited layer, which is that stickiness that when you start to polish, it gums up your burrs because that's the
Yeah.
unpolymerized layer of composite, which will also lead to white lines. So
Okay.
oxygen, the deox is the product, or you can just go to Shoppers and buy glycerin, put it in a syringe, and squirt it around the tooth. You,
Kidding me. It's the
oh
same
yeah,
glycerin.
it's
Okay.
a little more flowable, but it's glycerin. It'll all you
Okay.
need is something to seal that and then light polymerize through that.
So you
So
said do you do your major finishing first, then
I
glycerin?
will I put the glycerin on, polymerize, and then I just do kind of a rough polish, get rid of some of the edges, make sure my
Okay.
contacts are clear because now I got to work on the 5 and the 7. So,
Okay.
so now I'm going to answer your other question. Oh, this is a burr. It's called a raptor burr or an
Wrap.
acorn burr. And
It
what
does look like an acorn. Okay.
this is what you use to create the occlusal anatomy on your restorations. Essentially, 2 passes with this burr, and you have 90% of your anatomy done.
Wow.
Yep.
That's amazing. What type of burrs, like where do you buy that from? What manufacturer?
I think we get it from Henry Schein. I think there's so many of them out there, like an acorn, raptor burr, and and
Okay.
and yeah, and we have a hand instrument that has the same shape as that burr, so that I'm reducing the amount of finishing I have to do by
Mm.
by sculpting the composite because we use another product from Ivoclar called OptraSculpt.
Oh,
And
that's great.
yeah, those
Yes.
products are amazing for especially for the anterior. But more
Yes.
importantly, look at the interproximal box here and just consider how the magnification is on this. And you've got
Yes.
the flowable proximal box with your bulk fill composite on top of that, and you don't really see much of anything here.
Yeah, it's beautiful.
Yeah. Okay. So that's why these two composites are actually color coded. So you shouldn't see a difference in the
Okay.
shade. Okay.
Nice.
Now,
Okay. So you finished the 2.6 MOD. Now
and
you're working
now
on the 2.5 DO.
there you go. So now you've got your Garrison strategy matrix in, and because I don't need a contact on the distal of the 6, I just used a real matrix on the 6. You can just see that on you
Oh,
can
on the
see
7, you mean?
on the
On
7,
this,
sorry, on the
yes.
7. Yeah.
You use real matrix on the 7 because it's like a 2.7 DO
Yep. And then you can
and
see
then
that
2.5 DO.
and
Okay.
it fits over the rubber dam clamp or under it. But
Oh,
imagine
nice.
imagine if you're using a Toffelmeyer. How?
Yeah,
How? It it it,
true.
it's not you're not going to be able to do it. Yeah. So when you're using the right instruments, it makes all of this work very simple, really. So now you go through your whole steps again. and you're building up your seven, you're building up the five, and this is your initial view of the three restorations prior to taking off the rubber dam. We've done our polishing with enhanced cups, ASAP polishers, sometimes brownie points, whatever I need to make this finish. And you can see that you've got decent anatomy, decent aesthetics. Yeah, the translucency, it's a bulk fill. I got news for you. Patient walked in with a silver filling, they're leaving with a tooth-colored filling. They love it.
That's true.
And patients look at this, and I show them this all the time. They will see that. But more importantly, look at the distal contact of the six and the distal contact of the five and six. When you
That's
ask,
beautiful.
I get asked all the time, why do we need sectional matrices? Well, sectional matrices do two things. They create that convex anatomy that every tooth has. A toffle
Yeah.
layer gives you this, and this
Yeah.
part of the marginal ridge will break all the time if you're using a Toffelmeier.
Yeah. Dennis was showing with the Toppelmeier, you get the contact point like really high towards the incisal occlusal edge, and
Mhm.
it's like V-shaped.
Yep,
So
and
you're
that
going to get
breaks.
food impaction in there, and
Yeah,
and yeah, the marginal ridge breaks. And
right. So if you're doing composite posterior composites, a Toffelmeier really isn't in your armamentarium.
okay.
You need sectional matrices with the rings. And you can see,
So
an
I
hour
know it's
later,
beautiful.
he walks out like this.
So if you were just doing the 2/6 MOD, would you still just use the real matrix or would you use two
No,
sectionals?
no, I would use two sectionals at that point. If there's no,
Okay.
if the mesial of the seven and the distal of the five were normal or healthy or untouched,
Yes.
two sectionals, absolutely.
Okay. Good. Wow, that's fantastic. Thanks for sharing that.
So that I think answers a lot of questions.
Yeah, it does. It
When
answered a lot. Now, I do have another question about the snowplow technique, where you're placing some flowable composite at the bottom of your interproximal box, not curing it, then adding some composite over top, and then curing it all together.
okay, so the snowplow technique was originally uh, uh, coined by David Clark when he was introducing the BioClear many years ago. And you were using one type of composite and you were just pushing it through to engage all of your preparation. The problem is, okay, so a snowplow technique, for those of you who don't know, you have a layer of uncured, low viscosity, flowable composite in the cavity prep. It's followed by a higher viscosity, a bulk filled hybrid, and it's pushed through, and then you polymerize them together. So you've got one massive composite. That works great in the anterior where the C factor is not a problem because of your ratio of bonded to unbonded walls. The other concern is shade matching. If your flowable doesn't match your hybrid, you're going to see it, whether it's in the anterior or posterior, it's going to be visible. So in the posterior, what I've seen from a lot of dentists and work that I've seen is most dentists don't take the time to matrix and wedge properly. So what happens in the snowplow technique in the posterior, you get too many overhangs because of poor wedging and poor matrix placement. So I don't like to do that. Now, I have done it with the Tetrix system because it's coordinated together, both from a shade perspective and a light polymerization perspective. So your chemistry is the same. But anytime I do snowplow, it's pretty much just in the anterior. I don't like doing it in the posterior.
Okay, great.
Yeah.
And then how about for subgingival restorations? Do you
Okay.
put glass ionomer at the bottom of the box? What do you do?
Subgingival restorations, theoretically, if you can't etch cementum. So I'm going to go back to Garrison, and they've come up with a kit called the Deep Margin Elevation Kit.
I have it. It's great.
There you go. So why would I put Fuji when I can put the deep margin elevation kit, do total etch with a bulkier flowable tetric power flow, polymerize it, swipe out the matrix systems, put the curved sectional matrix in.
Yes.
It's game changing. I do that instead of posterior crown lengthening for crowns for patients.
Oh,
I
that's
will
a
build
great
them.
idea.
Yeah, because and you can do that immediately. And you've raised your subgingival margin to the level of your papilla, and you've got a
Yeah.
super gingival crown margin. And people say, well, what about cementing? Well, the resin is on your base, the composite, and you're using a resin cement. Well, you're going to have to
Yes.
micro etch that, etch and bond it in. You've got two like materials, so there's no issue with cementing on top of a composite.
Oh my gosh, Dennis, this has been amazing. I wish I met you when I was a new grad. You gave so many pearls. I've been doing things wrong. All
No,
these,
don't think of it
but now we
wrong.
can do things right.
Just think of it as different.
Yes, that's true.
It's not wrong. It's how
Okay,
can it
good.
be
Thank you.
wrong with how can it be wrong when that's what we knew
Yeah, it's true. So just to recap, use rubber dam,
all the time,
warm your composite and your
all the time.
flowable, use bulk fill, especially tetric power, bulk fill,
Yep,
double your margins, pumice, microbraid, and also etch, total etch the entire tooth, not just the prep. You like to use Optibond Flow. I love that one too. And then you're going to, so for layering, if you have a wide prep, layer towards the buccal and towards the lingual. Re-wet your dentin. I forgot about that with G5 or chlorhexidine.
absolutely. Yeah.
Yes.
And if you're using a self-etched system, Clearfill makes a wonderful product, but what you have to know is you must etch your enamel margins. Because if you don't etch your enamel margins, the pH of that clear fill system is not enough to fully etch your enamel. So you need to pre-etch your enamel margins, then use clear fill.
Okay, good. And then for matrix systems, we both love the same thing, Garrison, the real matrix, and the strategy, the blue strategy ring especially.
And I
Make
use
sure
dual
you're,
force. We have
oh,
Triodent.
dual force is good too.
I
Yeah.
have them all because I've been doing this so long. I've got them all.
Yeah, and you have to have different things because sometimes one thing,
Absolutely.
one matrix band or wedge doesn't work, so you need other things.
Right.
And then after you do, and to use the acorn burr
Yep.
or the
Mhm.
raptor burr,
Yep.
after you complete your restoration, put glycerin before you finish.
Correct.
Good. Did I miss anything?
No, I think we caught it all. Yeah. One of the things with bulk fills, what people have to appreciate is we are also running a business. And if you can't do dentistry in an efficient and profitable manner, you're not going to have fun.
Yeah.
You're not going to have fun doing dentistry. The bulk fill in the posterior is can make your dentistry more efficient and easier for you. In most composites in the anterior, I will use a single shade composite, a universal shade, like I'll have one shade. When I need to layer a composite for aesthetics, that's a whole different procedure. That's a
Yeah.
whole different price point for a patient because that's going to
Mm,
take time. But
yes.
for everyday dentistry, universal composites in the anterior, bulk fill in the posterior will make you a very happy camper.
Oh, good. Well, you made all of us happy. You solved a lot of our restorative challenges. So thank you, Dennis.
My
So
pleasure.
if the audience wants to contact you, what's the best way?
Best way is drdennismarangos at gmail.com.
Okay. And do you
And
have any courses coming up? Oh, go ahead.
oh yeah,
Dr. Dennis Marangos
and
at
just in the subject
gmail.com.
in the subject line, just put question from podcast or something like that, so I
Okay.
know I know where it's coming from. I'm heading out to BC in a couple of weeks, which would make it about the middle of September. I'm doing a 2-day course. On day one is I don't want to be a single tooth dentist anymore. It's how to take your practice from single tooth dentistry to more advanced restorative dentistry that makes you and your practice more um, more fun to be at and more fun to work. And you're not working on, patient comes in with a broken tooth, you fix it, the next patient, always putting out fires. How to be
Yes.
more of a super GP. I'm doing that day
Yeah.
one, and day two is on we're calling it communicating with confidence, a course on communication, case presentation, and it ties in with the restorative part from day one. So that's 2 days coming up, and there might be a couple of more coming up later on. But for now, that's all I got on the books. That's all I'm working on right now.
Good. So for that course in September, who's hosting that course?
It's a group out in BC. It's called Ocean Ceramics Dental Lab.
Okay.
And I've been out there a few times I'm almost out there once a year. And I've taught a full mouth rehabilitation course for them over 2 days each time. So we cover a lot of interesting dentistry over those 2 days.
Oh, thank you, Dennis. I feel like the luckiest dentist in the world to be able to have this time with you, for you to answer all of my questions. You're definitely going to decrease the stress in my life and improve the outcomes for my patients because you've shared all of your experience with us. So thank you, Dennis. I really appreciate this.
And thank you very much for inviting me. This is a lot of fun.
Yeah. Yeah, I have to say this was my favorite podcast. So well done, Dennis. Thank you
Wow,
for
very much
sharing your time. Yes.
pleasure.
And thanks to the audience for listening in. Tune in next time. Grateful to all of you. Thank you, Dennis.
Thanks. Good night.
Thank you for listening to the New Dentist Study Club podcast. Listen to us on Spotify, watch us on YouTube, share and subscribe, and follow us on Instagram at New Dentist Study Club.